This is Dr. Asma. Okay. This is Dr. Asma from SIUT, and our fellow Dr. Shaista Faiz is going to present a case named Hidden Beneath the Surface. So over to Dr. Shaista.
Assalamu alaikum. I'm Dr. Shaista Faiz from SIUT, fellow Infectious Disease. Today I'm going to present the case named Hidden Beneath the Surface. So let's start. Today, it is a case of a 25-year-old male, unmarried, resident of Jalalabad, Afghanistan. And he underwent live-related renal transplant in August 2018 due to renal failure of unknown cause. His match was good. And he was started on immunosuppression with prednisolone, cyclosporine, and azathioprine. Azathioprine was stopped in November 2022 due to pancytopenia. And he achieved breast 15.9 milligram per deciliter after transplant. 5 years post-renal transplant, he developed difficulty in breathing for 5 days, preceded by mild cough for 15 days, fever, and lip swelling for 2 months. Then the history of presenting complaint. And he presented with gradual onset of fever, gradual onset of cough, which was dry, not associated with chest pain or hemoptysis, difficulty in breathing for 5 days, without any orthopnea, pre-and body swelling. Fever was often known from the start of illness and now had become high grade up to 102 degrees Fahrenheit, and the lip swelling also persisted. Past history, he did not have any significant past medical history after transplant that would require hospitalization. His graft functions remained stable with serum creatinine of 1.8 milligram per deciliter, and he never required intense immunosuppression due to rejection. Family and socioeconomic history. He was unmarried, lived in a joint family, unemployed and supported by his brothers. No history of exposure to cattle, pets, or birds. So then we examined him, and on examination, his general physical examination and vitals was quite stable, except his respiratory rate was 20 breaths per minute, but he was maintaining saturation at room air, mildly anemic, and he was having side bruise over his left thigh. On systemic examination, he was showing bilateral basic crackers on chest examination with mild hepatosplenomegaly. Cardiovascular and central nervous system were grossly intact. So we went for investigations. Renal investigations were done. Hemoglobin was 9.6, TLC 1.12, with 36% neutrophils and 56% lymphocytes. Platelets were 48,000. LDH was 974. MP was checked 3 times. That came out to be negative. Now the graft dysfunction has started. Creatinine was 4.57. Liver enzymes were mildly deranged. CRP was 2.6 milligram per deciliter. Procalcitonin level was 11.38. And all the viral markers were found to be negative. And then we took a chest X-ray that was showing bilateral infiltrates. And we are very privileged to have a very efficient radiological department. So we went for CT scan. And this is the CT scan. So
fellows, can anybody describe this CT scan?
No one is spoken.
Anybody?
डॉक्टर असमा नाम ही लेके पूछ ले मेरा ख्याल से, ऐसे तो कोई नहीं बोलेगा.
कौन है मुझे पता भी नहीं है. सर बड़े लोग.
Hera, please describe the CT scan.
Sorry. Can anybody describe the CT scan? Nalish, please.
बायलेटरल इन्फिल्ट्रेट्स दिख रहे हैं मुझे तो, और इसके अलावा जो है ना यानी कि दे आर मोर ऑन द मतलब दोनों तरफ से तो इक्वली लग रहे हैं, और साथ में हल्का सा ग्राउंड ग्लास हेज है. ओके, आई एम नॉट एबल टू अप्रिशिएट एनी प्लूरल इफ्यूजन, कोई सेप्टेशन मुझे तो नहीं दिख रही है. जैसे पैची से इन्फिल्ट्रेट्स हैं दोनों तरफ.
Okay, fine. कुछ और है? इसमें कुछ और नजर आ रहा है या सेम है?
इसमें थोड़ी रेटिकुलर शेडोइंग नजर आ रही है मुझे, और इसके अलावा मुझे तो इतना कुछ अप्रिशिएट नहीं हो रहा है इसके अंदर.
Okay, so bilateral nodular cavitatory lesions and involving the bases of the lungs, basically, posteriorly. Okay. So reporting क्या थी भाई डॉक्टर शाइस्ता?
There were multiple irregular nodules diffusely scattered in both lung fields, and there were multiple ill-defined patches of alveolar opacification, diffusely scattered in both lower lung zones with adjacent ground glass opacities, and that were likely suggestive of pneumonic consolidation. So on the basis of the history and CT scan findings, let's summarize first. It's a case of a renal transplant recipient who is resident of Afghanistan and presented with shortness of breath, fever, cough, along with pancytopenia and graft dysfunction, with bilateral nodular infiltrates on CD lung. So what are the differentials?
5 years post-transplant.
For 5 years post-transplant.
So fellows, what are the differentials?
मैडम कोई फेलो तो नहीं बोल रहा, ये मैं वैसे फेलो नहीं हूँ अब लेकिन मैं बोल देती हूँ मुझे ऐसे इसलिए मैंने कहा जरा फेलोज को थोड़ा स्पेस दिया मैंने पहले कि कोई बोल ले तो फिर.
हमारे पास यहाँ 2 फेलोज हैं, बताए
4 है बल्कि, चलिए फेलोज बताना
चार
शुरू
है,
करें.
पहले वो तो बताए ना, फिर मैं भी गलत कोई डायग्नोसिस बता.
SIUT के नहीं है ना.
And pneumonia, it could be due to the bacterial, fungus, and tuberculosis.
Tuberculosis.
पेशेंट है विद इम्यूनोसप्रेस्ड पीसीपी हाइलाइटेड हमारे उसमें होता है, फिर देन फंगल हम एस्परजिलस रख सकते हैं, सीएमवी न्यूमोनाइटिस हो सकता है पेशेंट के अंदर, एंड
PCP हो सकता है with a 98% से O2 saturation.
डाउन बायलैटरल क्रैप्स भी हैं तो डाउन द लिस्ट.
मैडम मैं तो पीसीपी को रखूंगी, क्योंकि पीसीपी के पेशेंट अमूमन एक्सर्शन के ऊपर ना दे फॉल, दे हैव लाइक दे हैव हाइपोक्सिया एंड डिस्निया, इट एक्चुअली वर्सन व्हेन द पेशेंट स्टार्ट वॉकिंग. तो मेरा ख्याल है रूम एयर के ऊपर इफ द पेशेंट इज लाइंग तो फिर तो शायद उसके साथ नॉर्मल हो, बट आई विल स्टिल कीप द पीसीपी ऑन द डिफरेंशियल लिस्ट, क्योंकि एलडीएच भी उसका बहुत ज्यादा हाई है और इसका गैलेक्टोमेनाइन मैंने देखा था नेगेटिव है, तो मैं तो एस्परजिलस को थोड़ा सा नीचे ही रखूंगी.
Okay. और what about मतलब immunosuppression भी इसकी बहुत ज्यादा हाई नहीं है. He didn't receive any ATG or Solumedrol lately. Also, his match was fine. He was on lowish immunosuppression, cyclosporin, azathioprine only, cyclosporin and steroids only. And now it's 5 years post-transplant.
So मैंने अभी पोस्ट रीनल ट्रांसप्लांट पेशेंट के अंदर क्रिप्टोकोकस निमोनिया देखा है, तो I'll put that also in the differential list as well, along with obviously tuberculosis and aspergillosis and the bacterial pneumonias that's जो कि normally हो ही जाते हैं.
Okay, so what about pancytopenia? Pancytopenia क्यों हो रहा है इसको? पैनसाइटोपेनिया होता है टीबी में या बैक्टीरियल निमोनिया में?
टीबी में अगर बोन मैरो इन्वॉल्वमेंट बिल्कुल, सीएमवी वैसे
CMV
नेगेटिव था वैसे इस पेशेंट का, लेकिन चल
Yes.
भी सकता है।
And CMV 5 years down the line with lowish immunosuppression is slightly unlikely. Any other thought? Pancytopenia.
Crypto also causes pancytopenia.
Again, cryptococcus is a disease of high immunosuppression. It's an opportunistic one. Any idea regarding his residence?
Did we perform his bone marrow biopsy at some stage?
What we look into that? The fellow
Okay, so ठीक है, तो differentials हमने बता दिए, differentials बता दें? अच्छा बता.
Lymphoma क्या है?
अच्छा, इसमें जो बोल रहे हैं तो वो भी देखते जाओ. सॉरी, मैंने देखा ही नहीं, हमने चैट साथ लगा दें क्या?
मैं बता रहा हूँ.
Okay, so differentials जो थे, okay, lymphoma. Well, okay, fine. So let's
CMV very unlikely because pneumonitis
of this nodular type of pneumonitis.
और last 6 months में कोई intense immunosuppression भी ना मिली baseline पे patient को.
Yeah. So हमने भी एक broad से हमने भी आप लोगों की तरह ही broad से differentials सोचे थे, बता दें. Sorry,
So differentials were thought of pneumocystis jirovecii pneumonia, tuberculosis, rhodococcus pneumonia, invasive pulmonary aspergillosis, viral infections, COVID-H1N1 and CMV, nocardia, chemically-acquired pneumonia, atypical bacterial pneumonia, and non-infectious causes were also in our mind. So what next?
Madam, why rhodococcus?
Why rhodococcus?
So
Rhodococcus.
it is one of the most commonly missed pneumonic pathogen actually, which we usually miss because we don't think about that as usually being missed. But rhodococcus is quite common. In few series, it has been reported that it is the 5th most common cause of pneumonia in immunocompromised patients. Although
And-
there was no history of CATLs that
Yeah.
we specifically asked, but probably it can be in differentials, and it should be in differentials. Our family, whenever we ask our micro, they should process GPR because usually they think that the gram-positive rods in sputum maybe just contamination, or they ignore that, but it's they should process that, and then we can pick this up.
So what next? What should be done now?
Do we have any specific immunosuppression which causes like this presentation? Any immunosuppressant which can present like exactly like this, although patient is not taking it currently, but its presentation can be like pneumonitis.
Sacrolimus.
Usually mTOR inhibitors. That's sirolimus can present with pneumonitis, interstitial pneumonitis. I think our transplant population less than 2% on sirolimus. We usually have TAC as a MMF or steroids. Just like this is very good match. That's why this is on minimum immunosuppression.
So should we
Okay.
proceed further?
Yeah.
So how should we proceed further?
Somebody has said bone marrow biopsy.
And
You want to
Sibelle?
do it?
Okay. There are lots of findings in CT chest, so why not go for a bronchoalveolar lavage?
Yeah.
We did a bronchoalveolar lavage, but it did not show any significant findings. Even modified zeal-nasal stain, and PCB immunofluorescence were found to be negative. So what next? Any idea?
Hello here.
क्या करना चाहेंगे? अब बैल तो नेगेटिव आ गया.
जो कुछ सोचा था, whatever we had thought did not come out. आने खत्म कर दिया. 40.
Culture बता दो. Culture negative.
Culture negative.
सर आप बोले रूटीन कल्चर.
नहीं, bone marrow biopsy and culture. Bone marrow biopsy का culture.
Okay,
So-
fine. So bone marrow biopsy.
Okay, bone marrow biopsy was done. And what is showing?
It was a bone marrow biopsy. उसमें कुछ नजर आ रहा है. तो क्या नजर आ रहा है?
वेरी इंटरेस्टिंग. कौन बताएगा क्या नजर आ रहा है?
नहीं, आप नहीं बताएंगी.
हाँ, मैं नहीं बताऊंगी, मैं समझ गई हूँ. मैं पहले भी अफगानिस्तान कर रही थी.
ओहो.
तुमने ना बता के भी बता दिया. फिर चैट भी नहीं पड़ेगा.
चैट में क्या आ रहा है?
चैट से नहीं पढ़ रहा.
चैट में आ रहा है वैसे लिखा हुआ, लेकिन जो जिसने लिखा है वो बताए, खुद से बताए.
वो तो फैकल्टी है.
फैकल्टी है. तो नादिश क्या कह रही है? आप बताएं.
तो कंट्रोल करना पड़ेगा अपने आप.
एमएचटी गोट्स नजर आ रहे हैं. कहाँ नजर आ रहे हैं?
एरो से पॉइंट आउट कर ले. अब माउस.
हाँ, माउस से पॉइंट आउट बताएं. डॉक्टर नादिश बताएंगी, हमारी फेलो फ्रॉम
Trauma center.
ट्रॉमा सेंटर. जोर से बोले. ये तो न्यूक्लियस है.
This is macrophage.
दिस इज न्यूट्रोफिल.
इसके अलावा तो यही है.
ये बड़ा सा ये क्या है? बड़ा सा जो
ये वाला?
ये जो आप यहाँ पॉइंट कर रही थी पहले.
ये कर रही थी.
हाँ, ये
मैं
चीज़
basically यही कर रही थी.
ये क्या है?
यही है.
ये पूरा इन्वेस्टिगेट है.
नहीं सारे.
ये छोटे छोटे जो है ना.
सारे.
These are investigators of what? Leishmania. So this is जो शास्त्र बताएं. Very
These
good.
are the macrophage. Leishmania and Donovan. What is?
ये भी मुझे डॉक्टर समरीन ने ही बताया था.
So this is basically what? This is a large macrophage.
Macrophage that is showing multiple Leishmania and Donovan bodies. And these are the neutrophils and neutrocytes. Okay. And the bone marrow biopsy report. Bone biopsy. And macrophages were showing phagocytic activity, and many of them contain Leishmania and Donovan bodies. And bone marrow aspirate findings were consistent with the diagnosis of leishmaniasis. So the final diagnosis came out to be leishmaniasis.
And the
And
thing
it's,
is that lip lesion, which we deliberately hid before, it was like this.
It
He
was-
came in with this lip lesion for the last 2 months and then presented with lung infiltrates. So then the biopsy showed this. So our final diagnosis was
disseminated leishmaniasis with pulmonary involvement.
डॉक्टर रमेश
Okay.
पूछ रही है कि leishmaniasis causes pneumonia.
Yeah, this is the main cause of presenting this case. This is a rare thing. Leishmania, does it cause pulmonary lesions or not? So Dr. Shaista will going to tell us. She has did her literature search, and she's presenting the cause of pulmonary involvement in leishmaniasis.
And first we see the course of illness. A patient was started on liposomal amphotericin 5 mg per kg IV, not in 8 days, along with tablet multifosin. But the very next day, he was shifted to ICU due to severe shortness of breath, hemoptysis along with chest pain. First, he was put on non-invasive ventilation and then on mechanical ventilator. And after a few hours, he did not survive and expired the same night. It was very unfortunate, but this is. So now we are going to present leishmaniasis. First, a quick review about leishmaniasis, and then we will tell review and I'll tell you about literature search about leishmaniasis in transplant recipients. So leishmaniasis is a vector-borne infection and is transmitted through the bite of two types of sandflies: Flutzomia, which is prevalent in New World, and Phlebotomin, which is prevalent in Old World. And these are the pictures. And these are the types and geographical distribution of leishmania parasites. Three clinical forms exist: cutaneous, visceral, and mucocutaneous. Mucocutaneous is caused mainly by Leishmania brasiliensis, amazoniensis, and visceral leishmaniasis is mainly caused by Donovani, infantum, and Jagassy. And cutaneous has many causes, and most common are major, Entropica, Mexicana, and Zibelliensis. And WHO data, which was published on January 2023, was showing visceral leishmaniasis cases mostly occurred in Brazil, East Africa, and India. And it is estimated that 50,000 to 90,000 new cases occur worldwide annually. Cutaneous leishmaniasis cases, 95% occur in Americas, Mediterranean bases, the Middle East, and Central Asia. And 600,000 to 10 lakh cases occur worldwide annually. And mucocutaneous leishmaniasis is most prevalent in Bolivia, Brazil, Ethiopia, and Peru. And this is the life cycle of leishmania. Leishmania morphologically occurs in two forms. One is round or oval, non-motile hemastigote form, which is found in mammalian hosts, mammalian reservoirs, and the infective form, which is promastigote, flagellated, and active form, which is found in sandfly vector. Sandfly takes a blood meal and injects promastigotes in human skin. And these promastigotes are phagocytized by macrophages or other types of mononuclear phagocytic cells. These promastigotes transform into hemastigotes and are transformed into other cells and infect other reticuloendothelial cells. And then the sandfly takes a blood meal again. These hemastigotes are converted into promastigotes in the midgut of the sandfly. And these promastigotes reach proboscis, and sandfly takes a blood meal again, and the cycle continues. And these are the three clinical types: visceral, cutaneous, and mucosal. Laboratory diagnosis. Demonstration of hemastigotes in smears of tissue aspirates is the gold standard for the diagnosis of visceral leishmaniasis. The sensitivity is, splenic smear sensitivity is more than 95%. Smear of bone marrow is sensitive 60 to 85%, and lymph node aspirates are sensitive 50%. Serology test is also available, ELISA and immunofluorescence antibody test. And rapid immunochromatographic tests are there. These detect antibodies to recombinant antigen RK30 for Leishmania infantum, and sensitivity is 98%, and specificity is 90%. And PCR test is also available. So now we are going to share a report published in Weekly Epidemiological Monitor in April 2021. This report shows leishmaniasis is endemic to Pakistan. The highest number reported was in 2019, that was 22,114, followed by 16,865 cases in 2021. And a study from KPK describes Pakistan being under cutaneous leishmaniasis dominant region, with only 7 cases of visceral leishmaniasis being reported in 2014. The incidence rate of VL is 0.03 cases per 10,000 inhabitants in Pakistan. Now, this is leishmaniasis in solid organ transplant. Okay, there's a quick literature review about leishmaniasis, solid organ, and hematopoietic stem cell transplant recipients. Visceral leishmaniasis occurs in less than 1% of solid organ transplant recipients in endemic countries. More than 2/3 cases of visceral leishmaniasis in solid organ transplant recipients have been reported from Mediterranean region. Mediterranean bases like Spain, Italy, and France. Around 100 cases have been published to date. 79% cases were in renal transplant recipients. VL in solid organ transplant recipients is caused by Leishmania donovani complex, that is Leishmania donovani, infantum, and Jagassy. The median age and diagnosis in the 5th decade of life, and males are affected more than females. A median interval of 18 months from the transplant to the onset of symptoms is estimated. Mode of transmission in solid organ transplant is in endemic region, it is transmitted by bite of Rhizomia of phlebotomous sandfly. In non-endemic regions, it is from travelers and migrants from endemic areas. Donor-derived infection, blood transfusion infection are also observed. And late reactivation of unrecognized latent infection in the face of immunocompromised state, along with latent infection, have also been observed in transplant recipients. So risk factors. A study on 36 patients in was showing high-dose corticosteroids as risk factor, and a case control study in 20 out of 100 patients post-transplant CMV and living with cats was found as a risk factor. Other risk factors reported were bacterial infections, cohabitation with dogs, chickens and birds, and low socioeconomic status, along with lack of access to drinking water. Clinical features is as for non-transplant patients like fever, hepatosplenomegaly, pancytopenia, weight loss in 1/3 of cases, along with weakness and myalgia. And graft dysfunction in transplanted kidneys was noted in 75% of cases. Coexisting infection in 20 out of 81 reported cases were also noted. Treatment is usually with the amphotericin B or liposomal amphotericin, better tolerated as compared to pentavalent antimonials in solid organ transplant. Liposomal amphotericin B, liposomal amphotericin was given for 10 days. And in relapsed case, liposomal amphotericin was given 4 mg per kg IV daily for 5 days and then weekly. Overall cure rate was 94% in 1 month, and dose of immunosuppressive drugs should be decreased whenever possible. 80% cases went into remission. Mortality was 16.7%. 73% cases remission was noted with graft dysfunction, and 26% cases there was relapse. In relapse cases, approximately 1/4 of successfully treated solid organ transplant recipients are known to relapse, sometimes more than once. All relapse episodes were manifested as visceral leishmaniasis. The reason of relapse was thought to be suboptimal dosing of medication. Relapse was treated with antimonials or liposomal amphotericin, and in some cases in combination with allopurinol and antimonials. Now we are presenting about visceral leishmaniasis with pulmonary involvement. A case report was published. A clinical and tomographic evaluation report was published in PLOS one and was showing pulmonary involvement in human visceral leishmaniasis. An observational cross-sectional study from Brazil described pulmonary involvement in human visceral leishmaniasis non-solid organ transplant. Cuff, tachypnea, and chest pain were the most common symptoms. Tomographic changes were ground glass opicities, reticular opicities, pleural effusion, and alveolar opicities. These findings were reversible and resolved with treatment. Co-infection with HIV, atypical findings like solitary pulmonary nodules and mediastinal lymph nodes were also noted. The involvement of respiratory system in visceral leishmaniasis deserves attention, but because it is more common than previously thought. There is another case report in a renal transplant recipient with pulmonary tuberculosis and visceral leishmaniasis, and a review of superimposed infection therapy approaches. This is a case of 39-year-old transplant patient who was admitted for elective coronary surgery. In the post-operating period, he developed spiking fever and his general condition did not improve, deteriorated. On investigation, cavity lesion was found in his lung. He was diagnosed to have tuberculosis and ATT was started, but he did not improve. His fever continued, and he developed pancytopenia and splenomegaly. So, bone marrow aspiration was done due to pancytopenia, and evaluation indicated leishmania parasites. He was successfully treated with a liposomal amphotericin, and complete cure was achieved during follow-up period of 10 months and without clinical relapse. And to the best of our knowledge, this may be the second case of visceral leishmaniasis involving lung in the kidney transplant recipient. However, our patient did not survive and did not give us a chance to treat him successfully. So,
okay, so this is a case of visceral leishmaniasis with pulmonary involvement, which is very rare. I think it's the second case because in the literature we couldn't find any transplant recipient with lung involvement. However, in one review of literature published in PLOS One, they reported that maybe the lung involvements are underreported in non-SIUT patients also. So interesting case. However, the patient died unfortunately, but we should think of leishmaniasis in our hyperendemic areas, and we should promptly start treatment. We tried our best, but he didn't give us a chance because of the pulmonary, because of the pneumonia. Patient with pneumonia and SIUT is a deadly combination. Very, very high mortality in our case. So this is a case.
So, thank you.
Thank you.
Dr. Asma, this is a very interesting case. A few queries. जब म्यूकोजल इन्वॉल्वमेंट भी की थी क्योंकि इसके लिप पे अल्सर था, तो और साथ साथ में विसरल इन्वॉल्वमेंट भी थी, तो ये म्यूको मतलब म्यूकोजल भी है और विसरल भी है, राइट? नॉट ओनली विसरल.
Yeah, you can say yes.
अच्छा, इसमें एक बात जो है ना वो ये कि जैसे ये इतनी सारी स्पीशीज हैं, जैसे लीशमैनिया डोनोवनाई और ट्रॉपिका, हमारे पास ये नहीं होता ना कि हम स्पीशिएट करके देखें कि व्हाट इज द एक्चुअल स्पीशीज व्हिच इज causing the lesion. Because I mean, I had a case where there was extensive skin involvement, also visceral involvement, and it came out बड़ी मुश्किल से उसका PCR एक जगह से करवाया था, तो वो लीशमैनिया ट्रॉपिका निकला था visceral involvement के साथ. So it might not be that this is only being डोनोवनाई. हम assume करते हैं कि डोनोवनाई है.
हाइड की थी ना, इसे हाइड हो. हाँ, हमारे पास एक मैंने बिकॉज ऑफ टाइम, लेकिन हमारे पास टाइम जल्दी से गुजर गया. एक हमने एक पेपर देखा है, एक स्टडी है जिसमें इन्होंने पाकिस्तान की बहुत अच्छी स्टडी है जिसमें उन्होंने स्पीशीज भी बताई थी. हाँ, पता है भी, इसमें देख लेते हैं.
इसमें है ये इसी वाली निकाल
जी, वो अगर हो तो दिखा दें.
हाँ,
कहाँ से होती है स्पीशिएशन, क्योंकि कराची में तो होती ही नहीं है शायद कहीं.
इधर है,
दूसरे फोल्डर में निकाल. मुझे दूसरा फोल्डर, दो फोल्डर्स में
कराची में कहीं से स्पीशिएशन होती है.
कराची में स्पीशिएशन आई डोंट नो. इन लोगों ने ओके AFIP में, तो ये नॉर्दर्न पाकिस्तान में ज्यादा अच्छी तरीके से इन्होंने स्टडी की है, क्योंकि वहाँ पर ज्यादा केसेस आते हैं.
यूएसबी में ना, में दो
आपस नहीं है.
हाँ है.
अच्छा, लेट्स एक हमने बड़े अच्छा सा पेपर मिला था, तो मैं वो शेयर करना चाह रही हूँ, क्योंकि हमने वो निकाल दिया था कि हमारा टाइम नहीं मिलेगा, लेकिन टाइम बहुत है. सो लेट्स डिस्कस दैट केस आल्सो. ये तो हमारा SIUT तो बहुत ही ज्यादा रेयर है, और SIUT में एक आध सी केस मिलता है हमें, लेकिन ये हम केस रिपोर्ट करेंगे अपनी को भी. लेकिन ये एक
तो why did he, I mean, he did not give you enough time to treat him? बहुत जल्दी एक्सपायर हुआ है.
बहुत जल्दी एक्सपायर हो गया. पल्मोनरी इन्वॉल्वमेंट जो है ना वो बहुत ज्यादा एक्सटेंसिव थी इसकी, और he then deteriorated very suddenly. I don't know, सुपर इम्पोज शायद बैक्टीरियल इन्फेक्शन और हुआ हो, उसको नहीं हुआ हो, लेकिन जो इसको कुटेनियस इसकी लिचमेनिया ट्रीट भी हुआ था लोकल. इसको लिप पे लीजन्स, लिप इंजेक्शंस मिले थे अफगानिस्तान में, लेकिन फिर ये ठीक नहीं हुआ क्योंकि यकीनन इम्यूनो कॉम्प्रोमाइज था. तो फिर ये खराब होके हमारे पास पहुंचा विद सीवियर पैनसाइटोपीनिया. लिप वो है, शेयर है,
एडवांस डिजीज थी ना, एडवांस डिजीज.
जी एग्जैक्टली. ये देखें, ये हमने एक बड़ा मतलब ये वाला, ये एक सिस्टमेटिक रिव्यू है. खुर्शीद एट ऑल ने क्या था कि कहाँ पर था, कहाँ ये छपा है, ये
हाइड हो रहा है.
वो पेपर कौन सा था, आई डोंट नो. बहरहाल पढ़ दो ये भी. So they divided leishmania into zoonotic, anthroponotic and visceral. तो क्या होता है बता दो.
In zoonotics, animals are also part of the cycle.
Yeah.
And in anthroponotic, only two, there are the vector swine fly and the human host, and there is no animal reservoir. And visceral leishmaniasis is the clinical form. And the study was aimed to especially map different forms of leishmaniasis in Pakistan. And extensive search was done from PubMed, NCBI, and Police Scholar. And 50 articles that focus on geographical distribution risk factors of the disease in Pakistan were obtained and systematically reviewed. Okay, high burden of cutaneous leishmaniasis was found in northern and western foci. Leishmania major was a chief causative agent of zoonotic cutaneous leishmaniasis that is prevalent in the arid and semi-arid climatic zone, with elevations between 45 and 2,837 meters. And maximum numbers were found at low elevations. Leishmania tropica cases were associated with the anthropogenic cutaneous leishmaniasis at elevations ranging from 551 to 2,837 meters. Majority cases at high elevations. And visceral leishmaniasis was caused sporadically distributed in the northern areas at elevations 1,432 to 2,837.
Mainly caused by leishmania infantum.
And the risk factors were mountainous communities, farming communities, presence of dogs, cattle, poor preventive measures, migration, and living in mud houses that provide resting houses for sandflies, and outdoor sleeping habits. So this was a study.
तो ये इंटरेस्टिंग है, इन्होंने भी 3 तरह के बताए, मेजर, ट्रॉपिका एंड इन्फेंटम.
हाँ, yes. Do you have the slide? I mean, can you send it to AFIP to see if it is which size it is? आप लोग, आपके पास तो होगी ना अभी इसकी जो एंटीबॉडीज है.
बोन मैरो की हमारे पास होंगी, हम कर सकते हैं. We'll try. Okay. AFIP वालों से पूछते हैं कि भी अब हमसे ले लो.
सिविलियन
PCR है ना?
सिविलियन. हाँ, PCR होगा ना.
या PCR होगा. We'll try, क्योंकि अफगानिस्तान है तो यकीनन हाई एलिवेशन में है. पता नहीं कौन सा वाला था, शायद इन्फेंटम ही था, पता नहीं क्या था, आई डोंट नो. खैर देखते हैं. लेकिन ये इन्होंने बड़ी अच्छी सी स्टडी करी, इन्होंने सब बताया कि लो एलिवेशन जो हमारा है सिंध में हमें लिस्मेनिया मेजर ही होता है ना, और जो हायर एलिवेशन है उसमें ट्रॉपिका है वो.
क्योंकि हम टेस्ट नहीं करते तो हमें पता तो नहीं है ना, हम तो सिर्फ अज्यूम करते हैं.
हाँ, लेकिन इन लोगों ने या यू आर राइट, लेकिन शायद इन्होंने PCR किया था. वैसे इनका हमने मेथड्स ही देखे, इन्होंने शायद PCR ही चेक किया था, पूरा PCR से किया था सारा.
हाँ, PCR से ही होता है.
नहीं, ये तो सॉरी, ये तो लिटरेचर सर्च था इनका. सारे जो जर्नल्स उन्होंने निकाले होंगे, जो भी पेपर्स, उसमें पता नहीं PCR ही हुआ होगा. देखना पड़ेगा.
एक्सीलेंट है.
Any other questions, comments? तारीफ के अलावा.
तारीफ बहुत है. ये बताइए कि ये जो सिस्टमिक रिव्यू में ये कौन से इलाके माउंटेनस एरियाज है ना, तो ये तो कश्मीर और शायद ये इवन जो है ना ये अफगानिस्तान के एरिया उसमें और बलूचिस्तान से केसेस ज्यादा मैंने देखे, और काफी वो जो है एडवांस किस्म के केसेस होते हैं.
फिर फोरम ग्रुप में शेयर कर देंगे.
मैम ये अगर हम लिप अल्सर की बायोप्सी करते स्टार्टिंग में, रादर देन जैसे इसका अल्सर था और इट वाज अ नॉन हीलिंग अल्सर, और अगर ये क्रॉनिक चला आ रहा था स्टार्टिंग, पता नहीं इसकी अल्सर की हिस्ट्री तो मुझे नहीं पता, तो इसकी यील्ड कितनी है अगर इसको मतलब रादर देन ये बोन मैरो की बायोप्सी?
इसके लिप अल्सर की वहां पर अफगानिस्तान में ट्रीटमेंट हो चुकी थी, लोकल उसको इंजेक्शंस मिले थे,
प्रूवन था ये.
और ये फिर ये पता वेल नॉट एग्जैक्टली प्रूवन. उसके बाद पेपर्स इतने खास नहीं थे, उसने सिर्फ कहा कुछ इंजेक्शन लगे थे, तो हमें लगा था कि ये शायद कुटेनियस लिचमेनिया था इसको पहले से. हमें कुछ थोड़ी सी इंडिकेशंस थी. हाँ, उसके बाद बहुत एग्जैक्ट पेपर्स नहीं थे. लेकिन फिर ये बायोलेटरल इन्फिल्ट्रेट्स है, तो फिर हम इन्फिल्ट्रेट्स की तरफ चले गए. पैनसाइटोपिनिया था, तो हमने जब बायोप्सी की तो पता चला ओ ये तो मतलब ये तो विसरल लिचमेनियासिस है. और फिर ये इसने हमें चांस नहीं दिया कि हम सोचे और उसको ट्रीट करते. सो ये जो लिप पे था ये बहुत पुराना था, और उसने थोड़ी बहुत ट्रीटमेंट ली थी. उसकी बायोप्सी की तो खैर हमने पास मौका ही नहीं मिला ना, वो इतना सिक होकर आया और फिर वो एकदम से लंग की तरफ चला गया.
So should we close?
Okay, thank you so much. Thank you. Thank you. Allah Hafiz.